Hello, I'm Kathy Antala, Vice President of Education at the Immune Deficiency Foundation, and I would like to welcome you to this session about primary immune regulatory disorders and unspecified primary immunodeficiencies. Thank you for joining us. Please note that, as always, the information shared today is not to be taken as medical information to take care of yourself, and that you should always contact a healthcare provider in regards to any health issue or health condition you have a concern about. Now, at this time, I would like to welcome and introduce our presenter, Dr. Alice Chan from the University of California in San Francisco. Thank you, Dr. Chan, for being with us today, and look forward to having you share information with us.
Thanks for having me. So today I just want to give an overview of primary immune regulatory disorders, or PIRD, and we'll touch a little bit also about unspecified primary immune regulatory disorders as well. So my disclosures are I am a consultant, occasionally to Invitae as well as to Thymine Therapeutics. All right, so just to give a roadmap for today's talk, I'm going to focus first on talking about broadly the different types of immune system problems. Then we'll go through a little bit more detail about the definition of PIRD disorders. We'll cover clinical features and causes of PIRD, and then we'll go through different types of examples of PIRD, and those include Ipex, CHI, Latte, STAT1 and STAT3 gain of function, and lastly, APDS. And then we'll touch a little bit about therapies broadly, and then a few of the specific example PIRDs will kind of go through specific treatments that can be used. And then lastly, we'll discuss a little bit about unspecified or suspected PIRD disorders, and then end with some new research in this area. All right. So let's get started. So broadly speaking, there are two different types of immune system problems. Basically, 2/3 of these genetic immune system problems are considered primary immune deficiency disorders. And these are patients that tend to have an underactive immune system. So what that means is when you get an infection, the immune system isn't working and doesn't know to fight off infections. And so these patients can oftentimes get very sick from it. A newer group of disorders, which represents roughly 1/3 of the genetic immune system problems, are due to problems with immune regulation. So this is a group of disorders that we are now calling primary immune regulatory disorders. And what these patients have is an immune system that tends to be overactive, and that the immune system can't figure out when to shut off and starts attacking different parts of the body. And oftentimes these patients need medications to calm down or decrease that immune response. And so they need immune suppressive medication. These patients can also get infections like we see in primary immune deficiency disorders, but the predominant feature is usually an overactive immune system. So let's talk a little bit more detail about what is a PIRD. So PIRDs are diseases that really are due to a breakdown in how the immune system is controlled. So I like to think about it kind of like a thermostat in your house where, during the summertime, you want to turn it down a little bit so that your house isn't super hot. And during the winter time, you want to be able to turn it up a little bit so that it's not super cold. And you basically want to keep, your temperature in your household right at the perfect spot. And so that's kind of what when problems happen with PIRD is that thermostat is broken and the immune system isn't able to turn on or turn off appropriately. And so these patients can get a variety of immune features such as autoimmunity. They can also get auto or hyper-inflammatory responses. They can get different types of infections. They can get lymphoproliferation. So this is basically a fancy word for big lymph nodes and big spleens that aren't caused by an infection. They can have certain types of malignancies or cancer. And some of these patients can develop pretty severe atopy or allergies, such as a really bad eczema or asthma that isn't well controlled. So, to help us to learn about what symptoms PERD patients have, we actually conducted a study surveying a whole bunch of physicians from across the United States as well as in Canada. And we asked them, for their PERD patients, what sort of clinical features do they have? So those are the hatched bars up here at the top, and what sort of organ systems are involved. So if we focus on what sort of clinical features these PERD patients have, we found that majority of patients, basically 75%, will have features of autoimmune diseases, but a good number of them also have immune deficiency features, so getting infections a lot. But they also can have autoinflammation as well as lymphoproliferation. And then we asked them what organ systems are involved. These are the blue bars. You can see that pretty much all organ systems can be involved in these types of diseases, but primarily these patients have gastrointestinal involvement. So that's basically a lot of inflammation that is happening in the gut or in the liver. And this is followed by, diseases that affect the skin, so 55%, and then hematologic disorders. So these are things like low red blood cells and low platelets that may be due to the fact that the immune system is attacking those red blood cells and platelets. But you can see the brain, various endocrine organs are affected, as well as lung tissue can be affected, and then the joints and bones can also be affected as well. So what are the different causes for PERD? So from our survey, we actually found that there are a variety of different genes that can cause a PERD-like disorder. And so I've shown here on the left side, basically the different types of genes that were reported in this survey that we did. And what we did was we clustered them into different groups of pathways or sort of shared function of these genes. And you can tell that all these different types of gene categories all play an important role in immune system pathways and how the immune system gets regulated. And so a variety of genes can cause PERD. And so how do you get one of these PERD disorders? Well, first off, it can potentially be inherited from a parent. So that can actually be a single change from one parent, or it could be two changes, meaning, one parent gave one change to the patient and the other parent gave another change to the patient, and two changes together are what leads to the PERD disorders. It can also be due to a spontaneous change. So what this means is, they didn't get it from, either of their parents. It just happened spontaneously that they have this mutation or this change, and it results in this disease. And these are typically called de novo mutations. So, a lot of different changes, genetic changes can lead to PERD disorders. So now I just like to go through the different types of examples of PERD disorders. So the first type is what we consider our classic PERD disorder, or Ipex. So Ipex stands for immune dysregulation, polyendocrinopathy, enteropathy, and X-linked disease. So Ipex is due to a change in the FOXP3 gene, and this gene is really important in controlling the function of a specific type of immune cells called Tregs, or regulatory T cells. And so what a regulatory T cell does is it basically sort of surveys the immune system and tells which cells should be active and which cells should stop being active. And so when this regulation is broken or is messed up, then the immune system can go haywire and start attacking different types of the body. And so, like I said, Apex is due to a problem in Treg function. And so the types of symptoms these patients can develop include diarrhea. And when they have a lot of diarrhea, you can have poor growth. They could also have pretty significant rashes. The most common type is a type called eczema. And this type of eczema can be very hard to control. Different types of common medication really may not be helpful enough to control the rash. And these patients can also develop type 1 diabetes. And so Ipex, like I said, is really the classic type of PERD. And again, defect in FOXP3 gene and problems with their Treg function. So the next type of disorder is a disease called CHI, which stands for CTLA4 haploinsufficiency with autoimmune infiltration. So this is a disease due to changes in the CTLA4 gene. And when there are changes in the CTLA4 gene, the immune system loses the ability to control an active immune response. So take, for example, you get an infection. Normally, the immune system comes in and regulates and turns down the immune system when the infection is cleared. But in these patients, you can't turn down an immune system that's been triggered. And so it can start attacking different parts of the body. And so what I've shown here on the right side is a figure where it lists all the different types of autoimmune processes that these patients can develop. So things like uveitis or inflammation in the eye, it can attack the thyroid, it can attack the gut, it can attack the joints. So basically all different types of the body can be attacked by the immune system in this disorder. So common symptoms that we see in these patients, they can develop big lymph nodes or spleens, so that's called lymphoproliferation. They can have diarrhea, especially if the immune system is attacking the gut. They can have lung disease, so they can get big sort of nodules in their lungs due to the immune system being active. The immune system can also attack the red blood cells or platelets, causing the red blood cells and platelets to be low. And some of these patients can also get a lot of infections and may have low IgG levels and require medicines to help prevent them from getting types of infections. So the next type of disease is Latte, which stands for LRBA deficiency with autoantibodies, Treg defects, autoimmune infiltrations, and enteropathy. So this is due to a change in a gene called LRBA. And this LRBA gene encodes a protein called LRBA protein, and it actually works together with the CTLA4 protein, which is the disease we had just talked about. And because these two proteins work together, the patients can have very similar features. And so how do these two proteins work together? So CTLA4 is actually a receptor on an immune cell, and the LRBA actually connects to it. And so when there's problems with either of these proteins, then the ability to turn down an active immune response isn't working correctly. And so these patients can get respiratory infections, big lymph nodes and spleens similar to CTLA4 patients. They can get diarrhea if the immune system starts attacking the gut. And they also can have low red blood cells and platelets because the immune system is attacking those types of cells as well. So just to summarize, LRBA and CTLA4, because they're linked together in the same pathway, they oftentimes share some similar features. The next group of disorders are STAT1 and STAT3 gain-of-function diseases. So these are two different diseases. So STAT1 gain-of-function are due to mutations in the STAT1 gene, and STAT3 gain-of-function are due to changes in the STAT3 gene. And what happens when there are changes in these genes is basically the immune cells start to attack the body. So what happens specifically in this disorder? So, this is a picture of a cell with a receptor, and this is basically trying to sense signals from outside of the cell. And when they are sensed through this receptor, it sort of triggers some messaging that happens to turn the cell on. And this messaging goes through these proteins called STAT proteins. And so when these STAT proteins become activated inappropriately, it causes the immune cells to turn on an immune system storm. And this storm basically can attack different parts of the body and also just not work appropriately. So for example, in STAT1 gain of function, patients can develop chronic mucocutaneous candidiasis. So basically this is a fungal infection that is happening in the mouth, for example, and it's because the immune system is not working appropriately. They can also develop a lot of autoimmune features. The immune system is attacking different parts of the body. For STAT3 gain of function, patients can develop a lot of diarrhea because the immune system is attacking their gut. They can have low red blood cells or low platelets because the immune system is attacking those type of cells. And they also can present with big lymph nodes and big spleens that aren't due to an infection. These are different features that you'll see in STAT1 and in STAT3 gain of function patients. So the last group of PER disorders that I wanted to highlight is a disease called APDS, which stands for activated phosphoninositide 3 kinase, or PI3K delta syndrome. So these are changes in genes that are involved in a specific immune signaling pathway called PI3K. And the two genes that are involved are PIK3CD or PIK3R1. And so what happens when there are changes in these genes, it causes the signaling pathway to be wrong. And the immune cells basically get confused. And they're not sure when the immune cells should be turned on and when the immune cells should be turned off. And so these patients can get a variety of symptoms, such as frequent respiratory infections. They can develop cancers such as lymphoma. They can develop big lymph nodes and spleen, something called lymphoproliferation. They can also have an attack on their red blood cells and their platelets by the immune system. And so these numbers can be low. And they can also develop diarrhea if the immune system starts attacking the gut. And so next, I just like to focus on the different types of therapies, broadly speaking, that are used to treat PERD. So like I had mentioned earlier, PERD disorders tend to be due to problems where the immune system is overactive. And so because of that, you need medicines to try and suppress the immune system or turn down the active immune response. And so the two broad categories of medicine are those include steroids. So these are typically like I think of it like sledgehammer medications to really calm down the immune system very quickly, but unfortunately they can have a lot of side effects if they're on the steroids for a really long period of time. And so if that's the case, we use another category of medicine called steroid sparing agents. And types of medicines that fall into these categories include monoclonal antibodies like TNF inhibitors or Rituximab or IL-6 inhibitors. Another group of types of medicines include small molecules like JAK inhibitors or JAK inhibitors, mycophenolate mofetil or methotrexate are all small molecule medicines that can help calm down the immune system. And so, this is probably the main group of medicines that these patients need, but some of these patients also need immune protective medicines because they're at increased risk for infections, either due to their genetic problem or partly because of the immune suppressive medications that they're already on. So some of these immune protective medicines include antibody replacement like IVIG or sub-Q IG. Some patients may need antibiotics or antimicrobial drugs to either help prevent infection or keep an infection controlled while they're on immune suppressive medication. So these are the types of medications that we use to help with keeping the immune system and keeping the body protected from infection. And then lastly, in certain types of PERD disorders, what is needed is actually an immune system replacement. So basically that's either a bone marrow transplant or hematopoietic stem cell transplant. So what that is basically taking the cells that make up the immune system. So these are called hematopoietic stem cells, and they're typically found in the bone marrow, and they make your platelets, your red blood cells, and your immune cells. And so what we're doing is we're replacing the patient's immune cells that has the PERD genetic defect with a donor cell that has no PERD defect, so that we can replace their immune system with the new donor cells that should correct any of their immune system problems. So next, I just like to focus on a few specific PERD therapies that are specific to their genetic cause. So I like to group these into 3 different categories. So the first category are the diseases CHI and Latte. And so as you might remember from the earlier slides, the gene problem for CHI is CTLA4. For Latte, it's LRBA. So these 2 genes, like I said, interact together in the same pathway. So they work in this CTLA4 pathway. And so when they're defective, this pathway doesn't work to control the immune system. And so the treatment that we use is actually giving the body some more CTLA4 protein. So this is the CTLA4 Ig. And the drug names for this include abatacept and belatacept. The second type of group of disorders are the STAT1 and STAT3 gain of function patients. So these are due to gene problems in either the STAT1 gene or the STAT3 gene. And broadly speaking, these genes are important in that JAK-STAT signaling pathway. So this is the messaging that's sort of transmitting an outside signal to the inside of a cell and telling the immune system to turn on or turn off. And these patients with these gene problems sort of have their cells sort of active and turned on a lot. And so medications that are used to sort of target this pathway include JAK inhibitors. Sometimes IL-6 inhibitors can be helpful. And the drug names include ruxolitinib or tofacitinib or tocilizumab. And then the last group of disorders is APDS. So the gene problems can either be due to PIK3CD or PIK3R1. And again, these 2 genes are important in the PI3 kinase pathway. And again, it makes, when this pathway is defective, the immune cells can't figure out when to turn on and turn off appropriately. And so medications that affect this pathway include mTOR inhibitors or PI3 kinase inhibitors. Drug names include sirolimus or linezolid. All right. And so lastly, I wanted just to touch on, those patients that may have an unspecified or a suspected PERD disorder, and just going through sort of what types of symptoms these patients may have. So patients can have frequent infections. They can develop autoimmune features. So things like where the immune system starts attacking their red blood cells and their platelets. They may actually have rheumatologic diagnoses, such as arthritis or lupus, for example. They can also have hyper or autoinflammatory diseases. So these diagnoses can include things like inflammatory bowel disease or IBD or hemophagocytic lymphohistiocytosis or HLH. Some of these patients can develop types of lymphoma or atypical cancers. So things that you wouldn't see in this specific type of age group can sometimes be a clue to an underlying PERD disorder. They can also have big lymph nodes or spleen, something called lymphoproliferation, where it's not due to any infection that's going on. And then lastly, some of these patients can have pretty significant allergies, things like eczema or asthma that's poorly controlled by standard therapy. So what do we do when we have a patient that may have a suspected PERD? So the first workup we do is usually look at their immune labs because we want to know what parts of their immune system are present and what parts are working. So the first thing is we look at immune cells and we look to see, are they present or absent? So things like T cells, B cells, NK cells, are they there or are they not there? Next, we want to know, is the immune system able to make antibodies? So do they make IgG? Do they make IgA, IgM, or IgE? Because sometimes that can give us clues as to which type of PERD disorder it is. And then lastly, it's important to know if the immune cells are actually working. And one of the easiest ways to do this is to see how the body responded to vaccines such as tetanus or the pneumococcal vaccine, because that's sort of a way where the vaccine is a way where we're challenging the immune system to make a protective response. And so we can know when we challenge the immune system, do they make those tetanus antibodies? Do they make those pneumococcal titers that's supposed to be in response to the pneumococcal vaccine? So that's a really helpful piece of information. And then lastly, more and more, I think many of us are doing gene testing a lot earlier because a lot of these PERD diagnoses can have a variety of immune lab features and a variety of symptom presentations. And really the genetic diagnosis is sort of the key to sort of confirming the defect. And so the different types of gene testing that people can do include a single gene test where you're basically looking at one gene and seeing if there are any spelling changes in those genes. There's also gene panel sequencing, which is basically looking at sometimes 10 genes or sometimes several hundred genes all at one time that may have a very similar clinical picture. And again, looking for spelling changes. There's whole exome sequencing, which is a type of technology where you're pretty much looking at all of the coding gene sequencing in the body. So this looks at, not only immune genes, but all the genes, that are expressed in the body. You're looking for spelling changes. And then lastly, there's whole genome sequencing, which is looking for any type of spelling change that may be happening in the instruction book for your body. Because sometimes, the spelling changes may not be in the specific coding region, but maybe in the outside region that controls what the coding region does. So this basically sequences everything. All right. And then lastly, I just want to end on just some, what's the new research that's happening in PERD? So one of the new studies, that many of us will be embarking on soon is a natural history study on PERD patients, because this is a relatively newer group of disorders that we're understanding, and we really don't know, what is the natural history like. How do patients evolve over time as they go from when they're a baby to adulthood, and what types of treatments are beneficial, what types of treatments may help, early on and may not work later on, and which of these patients may actually benefit from a stem cell transplant early on, or which type of patients that doesn't work for. So these are sort of the questions that we're hoping to understand with this natural history study. And then certainly there are lots of new PERD genes that are being discovered. I would say there's usually a new gene or variant that's coming out every couple of weeks or months. And so it's a rapidly changing area and needing to keep up to date on these new sort of gene diagnoses that could explain some of the suspected PERD patients that we have. And then lastly, there are also new therapies that are constantly being sort of added to our, medication armamentarium. So these can be sort of targeted drugs that target specific pathways that maybe we know that they have a gene defect in. There's also gene therapy that's happening in certain types of PERDs. And then in the future, there will probably be gene editing that could be used to help treat some of these PERD disorders as well. All right. So just some take-home points, for you guys is PIRD stands for primary immune regulatory disorders. It's basically diseases that are caused by a breakdown in the control of the immune response. So like I said, I think about it like a thermostat is broken for the immune system and it doesn't know when to turn on and turn up and turn down appropriately. And so because of this, they can have a variety of different clinical features like autoimmune diseases, hyperinflammatory diseases. They can be susceptible to different types of infections. They can develop lymphoproliferation, which is a term for big spleens and big lymph nodes that aren't due to infection. They can have malignancies or cancers. They can also have severe atopy or allergies like bad eczema or bad asthma, for example. They can be caused by a variety of different genes, and certainly there are always new ones that are being sort of discovered and published, and so it keeps all of us on our toes. And the therapies can be broadly grouped into therapies that suppress the immune system, so trying to turn down an overactive immune system, or protective medicines such as immunoglobulin replacement or antibiotic prophylaxis to keep patients from getting types of infections. And then in some cases, these patients need a whole immune system replacement with a hematopoietic stem cell transplant. And so these are the types of therapies that can be used. So thank you again for your time. I hope this talk was helpful and provided some useful information to you guys.
Thank you. Thank you, Dr. Chan. Wonderful information. I learned so much. And we do have some questions submitted by our attendees. So I'm going to start with the first one.
Sure.
The first question, this person's insurance company is, it says they're requiring, they will approve gene testing if it provides a treatment. So the question is, how would genetic testing help provide a treatment? Because that's the only way insurance is going to approve it for this person.
Yeah, it's certainly a problem. We fight often insurance companies a lot, but I basically argue with the insurance companies that if we can find a specific diagnosis, sometimes we know exactly what medicines to give the patient. So take, for example, the disease of the chai or latte, the CTLA4 or LRBA deficiency. Like if we know that that the patient has that specific genetic disorder, we know that they need to be on a batterset or belatacept, because that can actually be super important in providing the missing part of their immune system that can help treat their disease. Or the the STAT and STAT1 or STAT3 gain of function patients, knowing that that's the specific genetic mutation, we can use JAK inhibitors. That has been really beneficial to treating those diseases. So I argue with insurance companies that yes, it's possible we may not get a hit, but if we get a hit, it can really narrow down the types of treatments that we use instead of just being a trial and error, of trying this medication and that medication and not knowing which one is the best one. The genetic mutation really will tell us this is the one we should really go after. And I will say, just to clarify, that sometimes it's not just that one, but that's the one that's needed. And then maybe we need to layer on other medicines on top of that. But we know that that's the pathway, that's a problem. And so we know that's the medicine that's needed.
Thank you. Next question. What percent of CTLA4 patients may actually have a new mutation? Is it possible that they didn't inherit the CHI from a parent, but actually got a de novo mutation?
Yes. So yes, CTLA4 deficiency can also come from a de novo mutation. It also is a little bit complicated because there's something called penetrance. And what that means is, a parent may actually have the same mutation and may not actually have symptoms as well. So it gets quite complicated. And we just need to know more about, why is it that even though they may have the same mutation, they may not actually have symptoms yet. Speaking of percentages, I think it's a little bit hard. I think we're just, we're needing to know more information, but certainly there can be de novo mutations as well as inherited ones. And like I said, inherited ones from parents or other, relatives that may not have any symptoms are also possible.
If a person has a primary immunodeficiency affecting IgG and thyroid nodules, bone and lung disease, multiple infections, is it possible to do genetic testing to find the specific gene or genes involved? And if so, how does a physician get this regulatory disorder testing, genetic testing requested?
Yeah. So, when patients have a variety of different features such as that, and sometimes it's sort of, unclear how, each of those are linked, sometimes it is helpful to get genetic testing done. There are a variety of companies that do gene testing panels. Usually when you're sort of unclear as to what the gene, what the gene could be, I do tend to do a gene panel where there's a whole bunch of genes. Gene panels have, the pricing has come down quite a bit. And then usually I argue with the insurance companies that, if I can find the gene mutation, sometimes I know what the right treatment is for the patient. And so that's usually the approach I try to do. So would recommend, just talking with your healthcare provider, and they can send, gene testing. Sometimes some providers aren't as comfortable sending genetic testing, and so you may need to get seen by a geneticist. I would say a lot of the immunologists are more and more comfortable with doing gene testing these days, and so it's possible your immunologist may be willing to just help get that test sent.
Besides sirolimus, everolimus, and abatacept, what treatments are on the horizon for a cure for CTLA4? And can a middle-aged person have these treatments? And what happens if an Epstein-Barr virus type virus has already caused a lymph node cancer?
Right. So great question. A lot of difficult points to it. With CTLA4 deficiency, abatacept really is sort of an important part of the treatment regimen. But when patients develop cancer, sometimes what needs to be considered is a bone marrow transplant. And I think that will need to be discussed, with your healthcare provider and even getting evaluated by a bone marrow transplant team, because there's a lot of different factors that go in to knowing whether that is sort of the best treatment and safest treatment for this, for you. But there are, we have done bone marrow transplants on CTLA4 patients to replace their immune system, especially if there's like cancer, for example, or a difficult to control immune system, that can be an option. But, a lot of other, important factors go into that decision. So would encourage you to talk to your healthcare provider. And like I said, even a transplant doctor might be helpful. And there are certain centers, I would say, that are maybe a little bit more comfortable with doing these types of transplants because they are a bit more complicated. And so I would encourage you to, reach out to, those centers, to get connected to those centers if transplant is a treatment option.
How high is the risk to give CTLA4 defect to a future child? And are there always so many symptoms?
Yeah, so that's great question. CTLA4 is one of those diseases that can be so variable, and how it presents can be so different. Like I have, different CTLA4 patients that look nothing alike. And some of them have, some can have the same mutation too and not have the same symptoms. And I think of it as sort of like, which immune cells, sort of are going crazy. And like in some patients, maybe it's certain types of immune cells, and other patients, it's other types of immune cells. And so it can be really hard to predict when you pass, if you were to pass it on to a child, what's that patient may have. But I will say if there were severe symptoms, we do get a little bit more worried when you pass it to a child that child could also have very severe symptoms. And also for CTLA4, not all of the mutations are actually passed on from generation to generation. Some can actually be a de novo mutation, and so it may not have actually been inherited. So there's a variety of different ways that CTLA4, that you can get CTLA4, and a variety of different ways of, variety of different severity in CTLA4 patients.
Is a lack of IgG, IgA, and IgM always from the CTLA4 defect, or is it possible that I got it from therapy with Rituximab against my thrombocytopenia 12 years ago? Before that, my immunoglobulins were normal.
Yeah, no, that's a great question. And I would say it's a really hard answer because, and it could also be a combination of both. So there are definitely CTLA4 patients over time that lose immunoglobulins and become more affected, that have more infections because they're losing immunoglobulins. Certainly rituximab therapy, could have impacted that process and, lose immunoglobulins as well. So it's really hard to say as to what is the true cause of that. I think it could be, a combination of both potentially.
Do you see good results with bone marrow transplants in primary immune regulatory disorders overall?
Yeah. So we did actually a survey, and as part of that survey, we looked at transplant outcomes, and it's really sort of variable. And I think this is why we want to do this natural history study to know. There are definitely certain types of genetic disorders where we know, a bone marrow transplant, especially early on, might actually be the best strategy to go. But there are also other disorders where we know that, medications are there that can actually help keep things in control. And certainly, from our paper, we know that, the transplants that were done more recently, so in the 2000s, because the technology and therapies that are used to do transplants have changed quite a bit. So the newer sort of transplant regimens for conditioning, those patients have fared a lot better. And it's also because we know better about these disorders. We know what to look for and how to sort of, get them through transplant. But it's really hard to say because it really does depend on which gene defect. And we just need more information. And that's why we really want to do this natural history study to help us know more, how to guide patients, in terms of treatments for the future.
Are primary immune regulatory disorders also considered primary immunodeficiencies, or are primary immune regulatory disorders under their own umbrella?
Now, this is a great question, and I think a little bit of semantics. And so, some people will say primary immune deficiency is the broader category, but we sort of want to designate that these disorders are different from, from the primary immune deficiencies that have more infections. So the distinguishing feature is really these PERDs have more overactive immune systems. They need more immune suppressive medications. But the primary immune deficiency diseases primarily have just infections, they're skids, that need a bone marrow transplant because they really have absent, immune cells that just don't work and they can't deal with any infections. But there's certainly a spectrum, and I think some of these regulatory genes may have more immune deficiency features, and some may have a little bit more, overactive immune features. But we're really trying to sort of make a distinction because the treatment is a little bit different, and how you think and manage them is a little bit different.
Other than a bone marrow transplant for TI, would a cord blood transplant ever be a good alternative?
Yeah.
How many cord blood transplants would cause less of an issue with graft versus host disease?
So, and I should say, I should clarify when I say bone marrow transplant or umbilical stem cell, hematopoietic stem cell transplant, that's sort of, I use it as an umbrella term. So certainly for hematopoietic stem cells, the source can either be a bone marrow, could be umbilical cord, could be peripheral, stem cell transplant. So there are all these different options. I think it all depends on the match, right? So it's a matter of like, do you have a good match from the bone marrow registry or the umbilical cord blood registry? So those are all important factors and to figure out which type of donor source should be used for your transplant.
Who are currently the top researchers in the area of primary immune regulatory disorders?
So there are a lot of great PI, researchers that are in this category. I would say, Troy Torgerson in Seattle is sort of like one of my mentors. Down at Texas Children's, there's Lisa Satter-Forbes and Megan Cooper at Washington University is also helpful. There's really a lot of different people. There's a lot of different groups, NIH, and I feel bad if I missed somebody as I'm mentioning this, because there really are a lot of great researchers. Each of them, may focus on a different type of PERD disorder because there really is a lot of genetic mutations, right? And so some people are very focused on one specific type of PERD, and others are on a different type of PERD. And so, I would say there's, you kind of happy to help connect people if they're interested in knowing, but a lot of great researchers who are trying to understand more about PERD disorders.
Is it possible to take a battersep during pregnancy?
Well, that's a tough question. I don't see as many adults as I'm primarily a pediatric person. And so I would say you would need, you should probably discuss that with your healthcare, your immunologist, as well as, your OBGYN doctor as well.
A PLCG2 mutation is presenting in siblings. Mm-hmm. How do we make a case for off-label use of medications in ultra-rare diseases?
Yeah, that is something I fight every day in my PERD clinic because these are very rare diseases. And oftentimes what I try to, argue in my notes is that, they have failed. There is no standard therapy for these types of patients usually. And we have to base it on, especially if we have a gene mutation, we have to base it on our understanding of the biology of that gene mutation, and arguing that, based on that is the best evidence for at least, trying certain types of medications, because we know based on biology, that's a pathway that could be affected. So that's usually how I go about trying to argue with insurance companies. I wouldn't say it's always successful, but I feel like I try to ground it in science, and papers for them to know, like, this is like the scientific data. This is all we have, and we have to do something to treat some of these patients' symptoms, because they can't just continue having all of these problems, because they will get more and more organ damage, and it becomes a big problem.
Where are the centers you were discussing who do transplants on PERDs?
Yeah. So a variety of different centers. I also want to, don't want to bias any centers, and also apologize if I left off any centers. Certainly NIH does a lot of the adult transplants. I know Seattle does a lot of these PERDs. This may sound biased, but at UCSF, we also do a lot of PERD transplants. Cincinnati Children's, Boston Children's, Texas Children's, WashU. There's a lot of big centers out there. CHOP also does a lot. So, I mean, there's a lot of big centers that do these types of PERD transplants. And again, my apologies for leaving out any big centers as I'm rattling them off now.
And another question similar. So what are the best places in the United States for treatment of PERD with less known mutations? Is there anybody in that category that you would suggest?
Yeah, I mean, there are clinics that are dedicated to these types of immune disorders. So obviously this is a bias, but I have a PERD clinic, and that's the clinic that I run here at UCSF. I know Texas Children also has sort of an immune dysregulation clinic, as well as CHOP. There's also a few other places like Atlanta, I know, Seattle has sort of a clinic like this. CHOP, Cincinnati, a lot, Boston Children's, a lot of these big centers are all starting to have these types of clinics where we're sort of more focused on these types of diseases and really focused on the genetics behind these diseases. WashU is another great place with Megan Cooper. All of these centers are really focused on these types of disorders.
My son is 31 and was diagnosed with STAT3 gain of function in July of 2020. Is he a candidate for any of the COVID-19 vaccinations? He is currently wheelchair bound and is afraid to leave the house.
Yes. So, I always want to say you should discuss it specifically with your immunologist, because I don't know any of the complications potentially in your history, but in general, what we have been recommending is vaccines for all of these types of patients, because we do worry that the COVID infection itself can be more harmful than any potential side effects of the vaccines. So we know there were a lot of the immunologists collected a case, sort of looked at all the different types of immune disorders and looked at COVID infections. And a lot of them can be very severe. And so that's why, we are recommending the vaccine to at least provide some protection. So do know you may not get the full protection from the COVID vaccine compared to a healthy individual, but at least you will have some protection to help you, if you were to get exposed and get the infection.
Thank you. That was the last question submitted. And what an amazing presentation. What amazing questions that were submitted, and what amazing answers you provided. Thank you. Thank you so much, Dr. Chan. And thank you to everybody who attended this session and submitted those great questions. And at this time, then, I would like to say I would like to thank Dr. Chan for volunteering her time to be with us today. And also, I hope that everybody now will be able to go and visit our sponsors and exhibitors, and also then be ready for the next session this afternoon, which is Swimming Upstream, Addressing Payer Challenges and Ensuring Access to Genetic Testing, which begins at 3:15. So again, thank you, everybody. Take care. Have a great day.